All right, good afternoon and welcome to our second of 4 live webinars we are hosting this year for the Northern Colorado community, dedicated to sharing knowledge and expertise when it comes to a healthy heart. All right, today we are talking about coronary artery disease, and our goal with this is to empower you with the knowledge so you can live a healthy life. All right, joining us live via Zoom today, we have Dr. Jason Hatch, you see him in the center there, and Dr. Brian Henry on the right. Dr. Hatch, let's start with you. So could you tell us a little bit more about your background and what you do there at Banner Health?
Yeah, thank you, Eric. Appreciate it. Again, my name is Jason Hatch. I live in the Northern Colorado area. I actually grew up here. I'm born and raised in Colorado, and my wife and I are from this area. We decided to come back to practice medicine. I'm an interventional cardiologist. I do a lot of minimally invasive procedures to help people with their heart valves as well as their coronary arteries. I also practice as the medical director for our group and enjoy taking care of people from every walk of life and every stage of life regarding their coronary disease or other heart issues. So thanks for having me.
Appreciate it, Dr. Hatch. All right, Dr. Henry, a little bit about yourself, what you do there at Banner Health.
So my name is Brian Henry. I'm originally from the East Coast, grew up in the Mid-Atlantic, did all my training in the Virginia and Western Pennsylvania area at the University of Pittsburgh. I am a non-invasive cardiologist. So Dr. Hatch mentioned he's an interventional cardiologist. So he fixes things that are wrong with the heart. I'm more of a photographer of the heart. I take pictures and I look at the pictures and I tell people like Dr. Hatch or our other colleagues, our surgeons, what's wrong with the heart, and then they go in and actually fix it. So I look, but I don't touch. I have been here at Banner for the last almost 5 years now. Came from Pittsburgh, and my wife and family, we enjoy being here and enjoy helping the people of Northern Colorado.
All right, Dr. Henry, I'm originally from Pittsburgh, so we'll get along during this webinar. This is perfect. For those joining us live, and we do have a good live audience joining us, here's how today's webinar is going to work. Some housekeeping, some critical information to start from Dr. Hatch and Dr. Henry there, and then we'll move into some previously submitted questions, and then if we have time, some live questions from our audience Q&A. So just a reminder, this is a live event. So if you're having some technical problems, we suggest logging off and logging back on. That tends to fix it. And if you'd like to submit a question, you can just use the chat feature right there on your screen. So again, if time permits, we'll try to get to some of those live questions. And throughout this webinar, we'll have a number on the screen that you can call to make an appointment. So let's start with you, Dr. Henry. Can you define coronary artery disease for us? So what exactly is it?
Sure. So in the most simplistic terms, coronary artery disease is where the major arteries around your heart that supply blood to your heart begin to experience a buildup of fatty material, generally made up of cholesterol, and we call those fatty buildups plaques. And when all of us are born, the arteries are completely normal. There's no buildup in them, but over time, these things begin to build up. The underlying biology of how that happens is very complex. It also takes often decades for this to happen. But it's also one of the most common things that happen in people. It's one of the most common causes of death, not just buildup of plaque or cholesterol within the arteries of the heart, but also in other vascular beds, in the arteries in your brain, that's known as a stroke, in the arteries in your neck or in your legs, things like that. So it's extremely common. It's a chronic process that starts early, even in the pediatric population. But by the time it starts to manifest itself as heart attacks, strokes, chest pain, various things like that we'll talk about, it takes many, many decades. But it's fundamentally buildup of plaque or cholesterol in the arteries around the heart.
And I'm assuming one of the first questions you get from patients then is, why do I have it? Why do I have coronary artery disease?
Sure. So a lot of times they like to blame their parents and they say, oh, well, I inherited this. And there's some truth to that. There is a hereditary component to this, especially people who develop cholesterol problems at a young age and have heart attacks in their 40s, 50s, things like that. That tends to be a genetic process. But largely it's related to the environment that we live in. We eat diets that are high in fats, whether we know it or not. And we live a long time compared to early humans. And so just that kind of constant exposure to high levels of cholesterol in the diet, and then living a long time, these things just gradually accumulate. There are also several medical conditions, including diabetes, genetic high cholesterol syndromes, high blood pressure, smoking, all these types of things that irritate the vessels and cause more buildup. So people with diabetes who smoke are more likely to have buildup than people who don't do those things. So it's a chronic process that occurs over decades.
All right, and we have live questions coming in as we speak, and actually I'll get to one of those now. I know I said we'd save them to the end, but I think this is important to, either one of you can address this. So is there a safe way to view current buildup? And I guess that's stemming into how is it diagnosed. So is there a safe way to view the current buildup?
If I understand it correctly, you said, is there, in other words, to diagnose that this is going on?
I'm assuming, yeah, that's the question coming
Yes.
in. Yep.
No problem. Yeah, no, that's a good question. So almost every imaging modality that we have, so in every way that we image the heart, has some way of detecting coronary disease. So if we do an EKG, we can see if you're having a heart attack or if you've already had a heart attack, and there's characteristic patterns of those things. We can use ultrasound or echocardiography to look at the heart. We can't see the arteries themselves, but we can see evidence of problems with the heart that could suggest the presence of blocked arteries. We can do things called stress testing or nuclear cardiology to look at blood flow around the heart to see if there's severe blockage or if you've had a heart attack. We can use MRI of the heart to see if there's evidence of injury to the heart or decreased blood flow around the heart that could suggest this. We can use CT, which is essentially X-ray, where we stack a bunch of X-ray pictures together, and we can actually look inside the arteries and see blockages. But the gold standard for diagnosis is what Dr. Hatch does, which is to put patients in the heart catheterization laboratory and actually put catheters, long thin tubes up near the heart, inject dye and take X-ray pictures. And that is considered the gold standard. So everything I do suggests or kind of points to those things, but Dr. Hatch is the one, and folks like him, that can have the gold standard of making the firmest diagnosis. What do you think of that, Dr. Hatch?
Yeah, yeah, absolutely. There are many different tests that we use that have different criteria regarding how sensitive or specific they are at actually getting to the bottom line. Do I have obstructive coronary artery disease? The gold standard is to be in the cardiac catheterization laboratory and do what we call an angiogram, where contrast or dye is injected into the vessels. And actually we can look inside the lumen of the vessels. And sometimes even if there are kind of borderline plaques, as Dr. Henry talked about, these plaques can be assessed with other imaging modalities like ultrasound or fractional flow reserve, which can measure kind of the blood flow down these vessels. So we have many tools in our arsenal to not only diagnose, but then after we actually see it, to determine whether or not it is truly obstructive or is it just a presence of coronary artery disease.
Thank you, Dr. Hatch.
Go ahead, Dr.
Yeah,
and the only reason that we don't always do coronary angiography and send you to someone like Dr. Hatch is that it is a procedure, and although it's very safe, there are some small risks. So at one time, really all we had was to send people to the cath lab to try to figure this out. So we've developed a lot of less invasive ways to do it. But at the end of the day, if we absolutely have to know, you go to Dr. Hatch. You don't go to me.
So, making that transition now from diagnosing to treatment, Dr. Hatch, what are some of the more common treatment options?
So there are several treatment options that are available. And when people come to the heart catheterization laboratory, the tool that we use is both diagnostic, as we talked about, where we can actually look at the arteries themselves, but it's also a therapeutic tool. So through those same little tubes that we use to actually inject the dye, we can also work through those same little tubes to actually put what we call a stent in. A stent is a small metal device, usually made out of a cobalt chromium or a platinum alloy, that goes inside the vessel, and it's kind of pushed against the wall of the vessel, kind of pushing the blockage out of the way, allowing the vessel to then heal. And then over that balloon that the stent was on, it's then removed. The wire is then also removed, and we're able to kind of take what was a blocked vessel and make it open. That's the most common technique and therapeutic tool that we have within our arsenal, within the world for that matter. at treating obstructive coronary disease. There are millions of these procedures that are done every single day throughout the world and helping people mitigate their coronary artery disease. There are instances, though, where the degree of blockage, the degree of plaque buildup, or maybe just the anatomy of someone's heart vessels do not allow me to put a stent in because of, again, the anatomy or whatever's going on, in which case they would be a better candidate for bypass surgery. And then there are some folks who, unfortunately, because of either the disease or the small size of their vessels or other mitigating factors, where we're not able to really use some of the tools and the stents or surgeries, and we have to rely on medications to help them treat their coronary artery disease.
That's funny you mentioned that, and I know I said we were going to wait till the end to get to some of the live audience questions, but they are coming in and they are relevant here. So what are some of those medications to reduce buildup?
So, like we talked about, the fundamental underlying problem is that you have buildup of fatty materials in the vessel walls of the heart. I mean, you can just think of it essentially as cholesterol. We'll call it that. But there's a lot of complex biology going on. It's not just that cholesterol is just layering there, like almost like sedimentation. It's not quite like that. It's an active process of where the cholesterol that's floating around the blood is being taken in the vessel wall, and the body's actually having an immunologic reaction to it. And so there's an inflammatory component to this as well. And the body is almost ingesting through macrophages, things like that, which are immune cells, the cholesterol, and it kind of builds up in those areas. So when we target how to prevent this or how to treat it, we're trying to lower your cholesterol, because if you have less cholesterol floating around in the blood, there's less of it to be incorporated into the vessel wall. That's an oversimplification of what's going on, but that's fundamentally what we're trying to do with medications like statins and then other newer cholesterol medicines that you may or may not have heard of. There's a lot of work going on looking at treating the inflammation component of this, and there's some early studies showing that very fancy anti-inflammatory medicines that you've never heard of, and quite frankly, I haven't heard of either. They're studying those, and those things are being effective. And then there's older medications that used for gout and other types of arthritis that are being looked at as well. And then, so that treats the kind of the underlying fundamental problem of the buildup. But then there's the part that Dr. Hatch kind of gets involved with, which is once these things build up and they become obstructive or only partially obstructive, sometimes they become unstable and they rupture, almost like a volcano. Might be too dramatic of an example, but essentially you have this buildup of plaque there, and it ruptures, and the body forms a blood clot on that. And that's when you start having a heart attack, and that's when we take you emergently to see Dr. Hatch. But some people get put on things like aspirin or other types of blood thinners to prevent those clots from forming when plaque rupture happens, almost like a backup plan. And it helps keep blood flowing down the artery until we can get you to Dr. Hatch to save your life. Does that seem like a good explanation, Jason?
No, I think that's
from your standpoint?
Yeah, that's exactly the way to think about it. Just like you talked about, it's a two-pronged approach. It's the inflammation as well as the cholesterol, or the free-flowing cholesterol that's in our blood vessels. And as Dr. Henry mentioned, it is a very complex process. These vessels operate in an environment it's incredibly complex with the macro and micro molecules that are interfacing with the walls of our arteries of our body. But ultimately, if you can mitigate the inflammatory process and also then decrease the cholesterol that's actually circulating, we hope to then decrease the amount of buildup that can occur in the arteries. And so that's why when we talk about risk factors for coronary disease, we focus on mitigating diabetes. If you have it, control it. If you smoke, stop. And, tobacco products in general, just get rid of them. Obesity factors into that. Hypertension. Even with high blood pressure, there's increased stress on the arteries, which can create an inflammatory environment. So these are all risk factors that then propagate within the arteries and develop more of this coronary atherosclerosis or coronary artery disease. What everyone worries about, if I have coronary artery disease, that means I'm going to have a heart attack. And that's really not the case. We can develop coronary artery disease that may or may not be obstructive. It doesn't necessarily mean that we're going to have a heart attack. Like Dr. Henry said, it's when those plaques become unstable that it becomes a problem and it becomes an acute heart attack. And that's a very different problem than if you have chronic buildup over time that gradually narrows the lumen of a vessel and creates symptoms. So symptoms are one thing, and then acute heart attack are something very different. They're both under this umbrella of coronary artery disease, but it doesn't, that we do treat them a little bit differently in how we go after them.
We're going to get to some of those. Go ahead, Dr.
Yeah,
Henry.
the common thread of everything that Dr. Hatch and I were alluding to when we talk about risk factors, like, smoking and being obese and having high blood pressure, those all seem different, and they are different. But when you study what happens to the vessel wall in high blood pressure, or when somebody smokes, or when someone has diabetes where the high blood sugar irritates the vessel wall, the same cellular processes in the vessel wall are ongoing, and there's oxidative stress and there's inflammatory response. And so fundamentally, even though these all seem like different things and we're just listing things off that are bad for you, at a biological level, the cells are experiencing certain stresses, inflammatory and oxidative stresses, that are accelerating these problems. So that's sort of the common thread of all this. It all comes down to the underlying biology, which is still very complex and not fully understood.
Got it. Okay, we're going to move on. Before we move on to some pre-submitted questions, one last thing, and you both can weigh in. And Dr. Hatch, I'll start with you. What are some common myths surrounding coronary artery disease?
Well, I think a lot of people think that if I have coronary artery disease, or even if I have a family history of coronary artery disease, I'm doomed to have it and I'm going to die young, and my life is going to be completely different. I just need to seal my faith, and I'm, whatever. And I think that's sort of a bad myth. This is something that is, first of all, preventable, and secondly, is something that's easily managed and treated. Like I said, millions of stents and heart cath procedures are done every day throughout the world, and people do very well. I mean, people, a generation ago would die from a heart attack, and nowadays, if you have a heart attack, you are expected to live a normal, healthy life if you kind of make some changes, or we can get the artery open with a stent or surgery or otherwise. So we have ways to not only treat it, but we can actually, mitigate some of these processes. The statin medicines that we use and the newer medicines that we call them PCSK9 inhibitors, we've noticed that with the plaque burden that we've seen in vessels in diagnostic testing in the cath lab or ultrasound within the vessels themselves, we've actually seen that these plaques can shrink or at least be stabilized with appropriate medical therapy. And I think that's reassuring. You might get a stress test or a CAT scan like Dr. Henry was talking about to diagnose that you have coronary disease. You may not have symptoms, but you've found that you have it, and it's imminently treatable. And I think that's the myth that I want to kind of help people kind of get out of their minds, is that Dad had a heart attack at age 70, so that means I'm going to have a heart attack. That's not the case. Now, if Dad had a heart attack at age 30, or Mom had a heart attack at age 30 or 40, that's a little bit different. That could be more of that genetic factor that Dr. Henry was talking about, and we need to be much more aggressive in modifying someone's risk for coronary disease, at least be more proactive at helping them avoid complications. That's the first myth that I think that I would like to hopefully get out of people's minds.
Yeah, Dr. Henry, I'll give you a chance too.
Yeah, everything Dr. Hatch said is correct, so I'm not going to add a whole lot to it. But speaking on the genetic part of this, just because you had a family member that had an event at a young age, that does put you at increased risk. But we believe we can largely modify most of those risks. And the reason that your family member had a problem was because we didn't know how to diagnose their problem, and we didn't have proper treatments for them. So the vast majority of these folks, when you start looking, you start finding problems that often in genetic, cholesterol-related things like that, and you can modify them. And you take someone who has terrible genetic cholesterol problems, and you significantly reduce that, it changes their risk dramatically. Their risk becomes very similar to that of the normal population. It's not like cancer genetics, where the reason you got cancer at a young age is because there's a problem with the gene, and that gene then caused the cancer. You can actually lower the cholesterol. You can lower blood pressure for people who have high high blood pressure, genetic high blood pressure, and then it resets their risk. So it is highly modifiable. It's not like some of the other things you read about with genetics where you have breast cancer at age 30 because the gene is in every cell in the body, things like that. We can modify these risks.
Yeah, and Eric, I think the other flip side of that myth is, just because we have excellent drugs or excellent treatment modalities for coronary disease, the other myth would be, I can do whatever I want. I don't need to take care of myself. Dr. Hatch and Dr. Henry are available. I'll just go see a cardiologist. We enjoy what we do. We enjoy taking care of heart disease. We recognize that if everyone kind of took care of themselves or they did certain things, that maybe we wouldn't have a job. I don't think that's the case, but truthfully, we don't want people to also think that I can do whatever I want. I can live however I want. I can eat however I want. I can smoke and do whatever, and it's not going to impact me at all. Or I have people that are going to just take care of me, and I'll still live okay. I think that's the other myth we don't want people to get trapped in either.
That's funny.
That's right. Yeah, Eric, he's right, because if you look at our society guidelines on how to manage patients with coronary artery disease, it's like 100+ pages long. But on page 1 is lifestyle modification. That's the very first thing that is mentioned. And it's like the last thing that a lot of us think about. So Dr. Hatch is exactly right about that.
And again, we have a great live audience submitting questions, and a question that just came in, if I can read, I'm reading it. How critical is exercise in lowering sodium intake for preventing more issues? And go ahead, Dr. Hatch.
Great question. So I get this often in the office, is how much should I exercise? And like Dr. Henry said, we have many tools in our arsenal to take care of this, but really it's between stents and surgeries and drugs, that's only about 50%. The other 50% is controllable lifestyle changes or modifications that each of us can make. And that is things like how we eat or certainly exercise. Now, there is a mountain of research regarding exercise and cardiovascular health. And I think everyone who's watching this is aware that anytime you go into a doctor's office or certainly a cardiologist's office, they're going to tell us to stay active and exercise. And we don't know, okay, what does that mean? Does that mean I need to go join the gym and I need to start, pounding out, hour exercise routines every single day? That's not the case. I mean, there's lots of literature about how much we should exercise, but ultimately we need people to be active. And we've often talked about the problem that we have in our society is that we too much screen use, too much sitting. We commute to places instead of walking or riding a bike, and so what happens is our activity level has just dropped off tremendously, and there's no debate about that. All of us recognize that we do a lot more sitting and looking at a screen all day as opposed to being physically active. Where our ancestors or the people that came before us spent every waking moment, farming and ranching and trying to just put food on their table from day in and day out, and they were much more active. Now, does that mean that they would have lived longer than us? I don't know if that's the case, but exercise is certainly probably one of the foundation pillars for lifestyle changes. And we recommend anywhere between 100 and 150 hours of moderate intensity exercise a week, which means that you should be spending about 20 to 30 minutes getting your pulse up, probably into that 50 to 65 or kind of 75 maximal heart rate period in order to kind of get the benefits of exercise. And then there's also the caveat that you can over exercise, right? I have many patients in my office who, they run a marathon a month, they've done these triathlons, and their coronary artery disease burden is about what someone else's would be had they not been exercising. So it's again, everything in moderation. We're not asking people to be training for marathons and Ironmans and being so fit and so healthy that they're actually putting increased stress on their heart and vessels, but that they're just getting enough activity that they're getting their heart rate up, they're exercising, and when you do that, you decrease that inflammation that we've been talking about. Brian, what do you think?
Yeah, so there's also, everything you said is true. There's a lot of research that's starting to be done on just physical movement. And that's what I think Dr. Hatch was alluding to. When we say exercise, I think we all think of being on the treadmill. But there's a lot of work that's being done on just step counts. So pedometers that measure steps, and now a lot of this wearable smart watches and things like that, cell phones, will monitor your physical movement. And people have started to hone in on the number of 7,500 steps a day. A lot of times you hear 10,000, that's based on nothing. That was just made up because it's a nice number. But there are actually the kind of cutoffs where if you do less than 2,000 steps or 2,500 steps a day, you are considered sedentary. And that's like a lot of days for me when I'm real busy at work, sitting in front of my computer. And then kind of that, 2,500 to 7,500 is like kind of active. And there appears to be this cut point, and the literature is always changing, but around 7,500 steps a day, where that's a good amount of activity. And 20,000 steps a day isn't necessarily going to have a huge added benefit. The other thing is age absolutely matters. I talk to a lot of people in the office, as does Dr. Hatch, who are in their 70s, 80s. The expectations for those folks are a lot different. And, as Dr. Hatch is saying, 20 minutes of walking around a day is going to be very comparable to doing more exercise. So age absolutely matters. That's what I'd say on that issue.
Yeah, and Eric, I always tell patients, I say, do things that you enjoy. If you enjoy walking the dog, and get a dog because the dog needs to be walked. If you enjoy rollerblading, you enjoy swimming, you enjoy playing basketball, do things you enjoy. Like, I don't really particularly enjoy running. That's not something that I enjoy. I don't enjoy putting shoes on, getting up at all hours of the morning or night, and going out and running, and it's just ugh. But other people, they do enjoy that. But yeah, when we talk about exercise, I think the most important thing is to say activity, like Dr. Henry was alluding to. We need to be more active. So if you find yourself, you've been on the couch for a little while watching a show or two, take a break. You could go up, walk up and down the stairs for a couple of times, and then come back and sit back down. It's that ability to kind of let the body know that it's supposed to be moved and not just sitting around. Now, to your other point of that question, the other part of that question regarding the sodium intake, we do recommend that people don't eat a lot of salt. Salt, unfortunately, can drive up your your blood pressure. And if you have high blood pressure, that certainly can cause issues. There's a lot of debate about what that cutoff should be. Is it 2,000? Is it 4,000 milligrams a day? I don't know. And the FDA and a lot of the nutrition labeling in the United States has kind of weighed in, and there's kind of back and forth. I tell people that if you're eating lots of foods out of boxes and cans that have high sodium levels in them, it's probably not good for you. Ultra-processed foods usually have lots of preservatives, and when they do, they use salt or salt-like compounds that tell your brain to hold on to water, and when it holds on to water, your blood pressure goes up. And this heart sort of kidney access will cause you to have higher blood pressure. It's one of the things that we use in patients that have severe heart failure or pump problems. We recommend that their sodium intake is diminished. So overall health, we should probably not eat as much salt as we do, and we could probably make the same recommendation regarding sugar. We should limit the amount of sugar we eat, because the more sugar, like Dr. Henry talked about, floating around our bloodstream, the more inflammation that occurs.
Got it. And I do want to move on to. Go ahead,
hey,
Dr.
Eric.
Yep.
Well, it's okay. So I had a dietitian tell me once, I think this is super useful information, talking about salt and generally food that is healthy versus unhealthy in general. They said if they sell it in the supermarket on the outside of the store, so you know how you walk in and you make a right and you kind of head through produce, and then you hang along the edges of the supermarket, that's where the food that is healthiest to eat is kept. And then anything in the middle, it's all in cans and boxes. That tends to be sort of the ultra processed, the less healthy stuff. So the nutritionist would tell people, just shop around the outside of the store. Don't go into the middle of the store. And every time I walk in, I remember that, and I go, yeah, this makes sense. Then I go to the middle of the store and get Doritos or something. But it is good advice. It is good advice.
I'm going home telling people the 10,000 step thing doesn't matter. I'm going to be telling everybody about the grocery store thing. So you're leaving me with some great information here. I do want to move on to some pre-submitted questions, and one of the biggest ones that stuck out for me is, can you reverse coronary artery disease? Can it be reversed? Dr. Hatch? Wow.
Yeah. So yes and no. From the standpoint that if you have coronary, so what happens is our body is undergoing this change where there's plaque buildup within the arteries. It begins a stabilization process, and it actually turns into what we call calcium. And it actually, when we do tests such as CAT scans or MRIs, or different tests, we can actually look, and it lights up almost like a light bulb on these tests. So we know that there's the presence of coronary disease, and people will get what we call a calcium score. It will kind of give us an idea of kind of what their burden is regarding coronary disease. And so that plaque is existing. We have not figured out a way to get rid of that. We have no good way of taking that out, vacuuming it out, giving you a drug that will magically kind of dissolve it. So if there's a presence of coronary disease or plaque buildup in the artery, you have coronary disease. Now the question then becomes, can I either arrest or stop the progression or reverse it a little bit? And the answer to that is yes. And that goes back to what we've been talking about, where as newer medications come online regarding inflammatory processes and actually mitigating inflammatory issues within the body, the cholesterol medications and minimizing the amount of cholesterol in our body, and then ultimately lifestyle changes with staying more active, eating correctly, that will arrest or at least help kind of shrink. There is a large trial that was done about 15 years ago that they actually took arteries of the coronary system and they put an ultrasound catheter down there and they measured sort of what the thickness of the plaque buildup was. And then they gave patients medicines like statin medicines and lifestyle changes, and they kind of came back 6 months, a year, 2 years later and did the same test where they measured with an ultrasound catheter what that thickness of that vessel was or how much plaque was there. And they did see regression. Now, it wasn't huge. We're talking micromillimeters, but it did regress. So the answer to your question is yes, it can be arrested and regress. If you have the presence of coronary calcium, there is the evidence of coronary artery disease, that is unlikely to ever go away.
Got it. Dr. Henry, we have more live questions coming in. The great audience submitting these questions. Here's another live one. Can depression or high levels of stress accelerate the disease?
Oh, that's an interesting question. Okay. So we got to talk about a concept in medicine called association versus causation. So do we have clear causation that being depressed will cause the underlying biology in the vessel to change and cause atherosclerosis or plaque buildup? I don't think that we can say that, but there's a mountain of literature showing that people with untreated mental health issues, not just depression, but most mental health issues that are left untreated, are more likely to have bad outcomes, cardiovascular outcomes, cancer outcomes. You go down the list. And so there's definite associations with the things that you're talking about. Now, in terms of stress, so stress is interesting because there are certain hormones that are increased during stress. Some of them you've heard of, adrenaline, maybe you've heard of cortisol. There's a whole bunch of other types of things. And those things can have direct effects on the vessel walls, causing some of the oxidative stresses that I talked about, some of the inflammatory responses. So I think the correct answer to that one is yes. Now, if you get angry at somebody driving on I-25 or up to the mountains on I-70, and that lasts 5 minutes, I don't think that's necessarily going to be the problem. But we do know that people that are in sort of this chronic state of stress, and there are certain ethnic groups of people, and there are certain people in certain parts of the world that live in a constant stressful environment, and they clearly have more cardiovascular disease and more problems. And there is a belief that this chronic stress is essentially like an inflammatory process, and this constant activation of these hormones and things, stress hormones, do have irritating effects on the vessel wall. So I think that's probably true, but I think just getting mad every once in a while is not going to do it.
Dr. Hatch, another live question coming in. When you have a stent, will buildup occur again in those places over time?
It certainly can, and it's for two different reasons. One, when a stent is placed in the artery, there's a fibrotic process, almost like a scar tissue process that wants to occur. Much like if you were to cut yourself or have some sort of lesion on your skin and it's removed, there's going to be a scar that's going to form. If we put a stent inside your vessel, that same process can occur. And so over the course of time, we've learned that we can use anti-cancer drugs actually and kind of layer the stent with those so that that process is arrested or stopped and it doesn't occur. However, if there's not the regular kind of risk factor decrease or modification that we've been talking about, such as taking appropriate cholesterol medications, using an aspirin, staying on your course of not smoking and controlling your diabetes, then yes, the process of buildup within the stent can definitely occur. We've noticed, though, over the course of each generation of stent is manufactured and the technology continues to get better and better, we have seen that there's been a great decrease in the number of problems with stents that we used to see, at least initially when we were looking at this in the late 90s, early 2000s.
And we have I can tell we have a live audience that really knows this topic well. An important question here: how do I know when to call 911 or drive myself to the ER?
I guess I'll take that one too. So
That's yours.
yeah, this is always a question because I think people, they're concerned for two reasons. One, they don't want to quote unquote overburden our EMS providers if it's something that's not significant. Or two, I don't want to get stuck with a bill from being an ambulance ride because I didn't need to go, or I don't want to have to go to the hospital if it was just reflux disease or something like that. And I definitely, I can empathize with people and patients as they're trying to figure out, okay, are my symptoms worrisome enough that I need to go to the hospital? It's been my practice and anecdotally talking with patients that they often know that there's something wrong and they say something's not right, I need to get medical help. So those are usually the acute heart attack patients where they don't feel well, they've broken out in a cold sweat, they have significant crushing chest pressure, or they feel short of breath, or their heart is racing, or something doesn't feel right, they feel nauseated. And it's different between men and women, but ultimately I recommend people call 911 if there's any discomfort in their chest that feels like a weight's on their chest, they can't breathe, and it's come on very acutely, and it doesn't seem to be getting better. Within 5, 10, 20 minutes, they're still kind of breathing hard, they don't look well, they don't feel well, get help immediately. All of us get chest pain. All of us have little twinges and little kind of things that go on in our chest because there's an esophagus, there's lungs, there's the heart, there's ribs, there's muscles, there's all kinds of things that can occur. And unfortunately, there's no nerve that sits right on the heart that tells us this is heart pain, you need to get something done. It's kind of what we call referred pain, and that referred pain can go to your arm, your neck. It can just feel like to your back. You can feel like this heaviness is there. If anytime someone's concerned, they should seek medical help. And we can do an evaluation, and if it's negative, whether it's the stress testing or blood work or EKGs, then I think we can reassure patients that there's nothing really going on and that we can do some other things to kind of rule out significant coronary artery disease so that if it does occur again, perhaps they can differentiate it. I always tell people, though, that if they don't feel well, if something's wrong, if you feel like something's wrong, do not just try to grunt it out or be stoic about it. Go get medical help immediately.
All right, great advice, Dr. Hatch. We're going to wrap up here, but want to give Dr. Hatch, want to give Dr. Henry an opportunity to sort of wrap us up here. We've learned a lot, we've talked about a lot, we've had some great questions come in. Dr. Henry, can you just kind of wrap us up here? I'll give you an opportunity here to close us out.
Sure. What I would tell folks about coronary artery disease is that it's preventable. Okay, if you start early with proper lifestyle modification, a lot of the things that we talked about, regardless of your ancestry, you can prevent yourself from having significant coronary artery disease. However, if you end up one day with chest pain and like Hatch told you, you call 911 and they bring you in and there's a problem and you end up on Dr. Hatch's table and he fixes your artery and he sends you home and then you come see me in clinic, there's a lot that I can do to prevent that from happening again. So there's primary prevention and there's secondary prevention. And Dr. Hatch and I both have patients who we've kept alive for a very long time, who've had bad problems, and they're doing just fine. And we're keeping them going.
Dr. Hatch?
I think that's great advice. In fact, the other thing I would say too is if you get diagnosed with coronary artery disease, not only is it not a death sentence, but it's imminently treatable. And a lot of the techniques, even if you have advanced coronary disease that, a generation ago, no one would have any kind of way of taking care of it, whether it was surgery or otherwise. We have lots of tools in our arsenal that have been developed over the course of the last even 10 years that have helped us and helped me deliver good care to patients and get their arteries not only open, but get them feeling better from a procedural aspect. And then couple that with medications, patients can do very well. And it's neat to see that this technology continues to get better and better. You know, it used to just be balloons and stents, and now we've moved into a realm where, you know, we can use all kinds of different devices, whether it's a kind of an we call atherectomy, which is sort of like a rotor-rooter device, or whether it's even what we call lithotripsy, or kind of a balloon that kind of shocks and kind of busts up the plaque so that we can put a stent in. There are a number of different techniques that we have. Even people that have had chronic occlusions for years, we can get those open and help them feel better with some of the techniques that we can employ at the cath lab or in the operating room.
All right, Dr. Hatch, Dr. Henry, thank you so much for spending some time with us this afternoon. I know you have very busy schedules, great information. Again, thank you so much.
Thank you.
Thank you, Eric. Have a good day.
All right, I want to thank all of you for attending today's webinar. Please share this link if you found the information helpful. And a reminder, you can always schedule an appointment with that number you saw on your screen there. Thanks again for watching, and we'll see you in a couple months.